Well, good morning everyone and welcome to the Dental Health Services Victoria Public Oral Health Innovations Conference, Journey to Value. I'm Angela Pipos, your facilitator for today, and my job is to make sure that things run smoothly. So can I please ask you to take your seats so we can get underway? Thank you. Lovely. Well, Auntie Di Kerr was going to be with us today, but unfortunately she's called in sick, so I would like to acknowledge the traditional custodians of the land on which we are gathered today, the people of the Kulin Nation, and pay respect to their elders past and present. Well, today's conference has the theme Journey to Value, and we're going to be exploring this theme throughout the day. But essentially it's about creating a healthier Victoria where more people can access care. I've been on a parallel journey in sport, a journey to equality. And I've been on this journey for 20 years, and I'm pleased to say that we're finally starting to make some progress. And change is a beautiful thing. And I can't stand here today after the week that we've had without mentioning AFL Women's. So forgive me if you're not a fan of this great game. I'll be as quick as I can. And apologies to our international guests who may not understand what I'm talking about. I was lucky to be in the thick of it over the past 8 weeks, but the last week I went to the Gold Coast and I hosted the official function for the AFL of the first ever AFL Women's Grand Final. My team then went on to win the thing, which was amazing. On Tuesday night, I hosted the AFLW Awards, and later that night, I left my voice on the dance floor. It has been a glorious week, and in my 20 years as a sports journalist and presenter, this is the best thing that's happened. And every time I say that, people ask, why is it so significant? Why is it so important? And for me, it's pretty simple, because Australian football is our national game, it's our Indigenous game, it's part of our cultural identity, it's in our blood. We all know that playwrights and poets and writers have written about Australian football, and painters have depicted men taking spectacular marks and kicking beautiful goals. And until now, women have been excluded from participating at the highest level and denied a clear pathway to play the game they love. So for me, AFLW is about more than kicking a winning score, as much as we like that. And apologies to Collingwood fans for talking about football today as well. It is about equality, fairness and respect. It's about inclusion and creating cultural change. And it's quite amazing how quickly that change can take hold over just 8 weeks. You can hear it in the conversations. We're hearing people say, did you see that great goal by Erin Phillips? You know, what about that mark by Sarah Perkins? Did I mention Erin Phillips? I'm very, very obsessed with her at the minute. But AFLW, after such a short period of time, feels like it belongs. And somehow it's managed to turn some of the most unsporty people I know into fans. One of my friends didn't know that a goal was worth 6 points until about 8 weeks ago. Now she's been to a game every week. And perhaps even more strange than that, I've developed a soft spot for Collingwood because I've met some of the players when I did my documentary about the rise of women in the game. Such is the power of AFLW. But this story is bigger than football. The AFLW is part of something greater, and that is the rise of women across all sport. And I've written about that in my brand new, beautiful book called Breaking the Mould, Taking a Hammer to Sexism in Sport. And just a quick story before we get on to things. I signed with this publisher at the start of 2015. After I signed, great things started to happen. The Matildas took us on that wild ride all the way to the quarterfinals of the World Cup, and they got a pay rise. The Southern Stars regained the Ashes, and they got a pay rise. Michelle Payne became the first woman to win the Melbourne Cup, and she told everyone to get stuffed. The Diamonds won the World Cup, and netball got a brand new National League, a 5-year broadcast deal on the Nine Network, and a pay rise. The AFL brought forward AFL Women's 3 years, and they got some money. Not enough, but they got some money. Anna Mears cycled her way into history, and there were other superb performances by our women, so many, too many to mention here today. All these athletes elbowed their way into the public's consciousness, generating a shift in mood and momentum, and that's what we're experiencing now. And all this happened after I signed my book deal, so I can only conclude that I have special powers. I can, by just putting pen to paper, make great things happen. So to all the women in the room, and men, if it's equality, respect and recognition that you're after, come and see me down the front or during morning tea and just bathe in my aura, and I'll be able to make great things happen. I'm only too happy to help. Okay, all jokes aside. What I want in sport is the same thing you want in your work, a fairer and healthier society. So I look forward to hearing throughout the day how things are progressing in your field. I hope they move a little more quickly than in my world of sport. I'd like to welcome today DHSV's special guests who are joining us. Welcome to you, and welcome one and all. We're in for a stimulating and challenging day, no doubt. A little bit of housekeeping. The bathrooms are to the right in the foyer, so head out there and turn right. Please turn your mobiles to silent, but remember to tweet throughout the day. The hashtag is on the holding slide. This is the modern way, is to tweet your way through a conference. The agenda is on your table. It clearly outlines the format of today, but if you have any issues, please see our staff and we'll be able to help. Okay, it's my pleasure now to introduce DHSV Board Chair, Dr. Zoe Wainer.
Many thanks. We might need to get you to write us a book on value-based healthcare, perhaps in the Australian healthcare system, so you can make some of that special powers shift our system a little more quickly. So I'd also like to acknowledge the traditional custodians of the land we're meeting on today and pay my respect to their elders, past and present, and elders of other Victorian and Australian Aboriginal communities. Good morning, everybody, and welcome to the Dental Health Services Victoria Public Oral Health Innovations Conference, Journey to Value. This conference is now in its 5th year and has gone from strength to strength. We launched this event because we wanted to provide an opportunity for people to come together and showcase the great work happening in public oral health sector and to discuss innovations for the future. A quick look at today's program shows how much this event has grown, from showcasing clinical projects to focusing on the big ideas that can transform oral health care. We are privileged to have a fantastic lineup of presenters for today's conference, and I'd like to extend a special welcome to them. In particular, our keynote speaker and dear friend, Jacob Lippa from the International Consortium for Health Outcome Measurement, who will talk about the what and why of value-based healthcare. We also extend a warm welcome to Dr. Diane Watson from the Victorian Agency for Health Information, Melanie Hay from the Victorian Cardiac Clinical Network, Harry Patsmanis from the Heart Foundation, Malcolm Passmore from Ramsay Healthcare, Karen Lang from Kyneton District Health Service, and those representing DHSV, Wainer Bischoff, Rana Yori, and of course our CEO, Deborah Cole. The Minister for Health, the Honourable Jill Hennessy, wanted to be here today, but unfortunately she had a prior engagement. She did, however, send us this video message.
Good morning, everyone, and welcome to the Dental Health Services Victoria Public Oral Health Innovations Conference. Only a conference dedicated to oral health could have such a wordy name. But today is going to be a terrific opportunity for you to come together to talk about how we might better support the oral health of all Victorians. The theme today is Journey to Value, and you'll be exploring value-based healthcare and what kind of principles can be applied to the public dental sector. It's an opportunity to showcase the wonderful work that you're doing to learn how we can better collaborate and develop initiatives in our local communities. It is so essential that people have access to high quality public dental programs, particularly for those who need it the most, no matter where they live. I certainly understand the importance of oral health to overall general health, and it's really important to continue as a government to invest. We've put in more than $206 million. That'll provide dental treatment to around 332,000 eligible Victorians this year. The funding also includes $2 million for a range of investments in dental services, including things like upgrades to the titanium IT system and new dental imaging technology, and that will help improve referrals, access to services, particularly for those in rural and regional Victoria. One of the initiatives I'm really enthusiastic about is a mobile van that will provide better access to dental health in rural and regional Victoria. I know that you are all extremely committed to improving oral health, particularly to those in our community that are vulnerable, including children, teenagers, adults and the elderly. But I also know that we've still got a lot of work to do. Dental conditions are the single largest cause of preventable hospital admissions for Victorian kids under the age of 10. We're already investing $1.8 million a year to promote oral health of Victorian children in statewide prevention initiatives, things like Smiles for Miles, Healthy Families, Healthy Smiles, and other programs to help. But we know we need to do more. And I hope today you've got the opportunity to build some fulfilling professional relationships and that you leave today feeling inspired about what you're going to be able to do in your own community. Make sure you use the time today, precious time away from work, to think, to plan, to actually reinvigorate yourselves, get inspired, make some wonderful new professional relationships. But know that we're incredibly grateful for the work that you do. We've got great opportunities to do a lot more. Have a terrific day.
I'd also like to welcome and thank our consumer representatives who continue to make such a fabulous contribution to DHSV. Thank you for being here with us. Also, congratulations to Dr. Martin Hall on his appointment as Chief Oral Health Advisor, and in this role he will be leading value-based healthcare. And thank you to Paula Bacchia for her contributions to the inaugural role, and best of luck in her cookbook writing endeavours. As most of you already know, last year we launched our new 5-year strategic plan for the future of oral health in Victoria. The plan was developed after extensive consultation with our partners, consumers and staff. Our new plan intends to disrupt and transform public oral health care and focuses on 4 key themes: improving health outcomes, improving the experience, establishing DHSV as a global leader with our local partners, being a great place to work and a great organisation to work with. What we're doing here today is in line with all of these themes because it's about creating a system that prioritises health outcomes through value-based care. This might sound very blunt, but what we're doing right now isn't working. Public patients have more oral disease and fewer teeth than the general population, but are also less likely to access services. And if we look at the general population, they don't have great oral health either. While we provide emergency care in a timely fashion, there are long waiting times for general care. Whilst patients wait, their oral health deteriorates. And when they do eventually walk through the doors of the dental clinic, they could receive care that does nothing to improve their health and well-being. There are preschool children who are not accessing oral health care in either the public or the private sector. There are school children and adolescents who are also not accessing services. There are settings where poor oral health care is particularly prevalent, but there is no access to health promotion and no prevention measures in place. Yes, we do a lot of things well, but we do need to overhaul the system if we want to see a real improvement in the oral health of Victorians, which is sustainable and has longevity. We're not alone in having to reassess our models of care. All over the world, health professionals are having to look at new ways of doing things. Why? Because the population is growing and ageing. There are rising rates of chronic disease and rising costs associated with providing care. And there is no bottomless pit of money. We have to use the funds we have as effectively and as efficiently as possible. We, along with the rest of the healthcare sector, can't afford to keep doing things the way they've always been done. We have to focus on providing value-based care, and that means identifying models of care that are cost-effective, but most importantly, focus on the outcomes that matter to patients. So today we're going to talk about value. What does it mean? What does it look like? How do we create a value-based system, and how do we measure it? It's not all about reducing cost. It's about making sure that every person is better off as a result of their intervention and care. We need clinicians to lead the change through a strong focus on clinical governance. We need you to ask, what procedure should I do? What prevention program do I support? Am I the right person to be providing this care at this time? How can I better involve the patient in this process? Think outside the box. Move away from habits and history. It's time. The board and the executive team will support you every step of the way. So what are we doing at the board and executive level to drive this change? We're working with the International Consortium for Health Outcome Measurement, ICHOM, or in the oral health sector we like to call them ICHOMP, to develop an international evidence-based way to measure oral health outcomes. We've also ensured that the new strategic plan considers the 5 population groups being pregnant women, infants, children and adolescents, adults and older adults over the age of 65. We will ensure our models of care have a strong focus on prevention, incorporating health promotion and clinical activities like fluoride interventions and minimally interventional dentistry. We also want the right mix of staff so that everyone is working to their full capacity. This is better for staff, and it's better for patients, and it's better for the system. Over the next 5 years, we will continue to focus on reducing health inequalities by reaching more people who are eligible for our services, especially priority groups. We'll analyse our data to better understand these groups and allocate resources where they're most needed. How will we know if we're doing a good job? Fewer children will be undergoing general anaesthetic for dental treatment. Less people who are eligible for our services will have untreated tooth decay. There will be more referrals between the general and oral health sectors. More children and pregnant women will be accessing routine care, and each population group will have better oral health. And we will know how to effectively and efficiently measure oral health outcomes. So I want us to all work together on creating a public oral health system that offers real value to the community, that helps more people access care and creates a healthier Victoria. Today is a great opportunity for us all to reassess the way we do things, to be inspired by new ideas, to walk away feeling motivated, to play our part in the journey to value. Thank you to everyone who has made today happen, and thank you to everyone working in the public oral health sector for your dedication and commitment to improving the health of the Victorian population. Enjoy the conference. Thank you.
Thank you, Zoe. The scene is set for an exciting and challenging day. Let's get stuck into it. Our first speaker is Jacob Lippa. Jacob is Director of Implementation, International Consortium for Outcomes Measurement, ICHOM, and Research Associate, Institute for Strategy and Competitiveness at Harvard Business School. Jacob leads ICHOM's portfolio of implementation work across the Americas and Asia Pacific, and manages its partnerships and strategic alliances in the region. Prior to joining ICHOM, he worked across the Institute for Healthcare Improvement and the Commonwealth Fund, conducting research on health systems performance. Jacob is trained as a Healthcare Quality Improvement Advisor and Patient Safety Officer, and he holds a Master's degree in Healthcare Policy and Management from Columbia University. He's done a lot. Please welcome Jacob Lippa.
Thank you, Angela, for the warm welcome. Good morning, everyone. Just wanted to say a big thank you also to Deborah Cole, Zoe Wainer, Dental Health Services of Victoria more broadly both for inviting me to speak here this morning, as well as being a strong supporter of our work at ICHOM. We'll have to figure out what the P stands for later, but I like that. It's better than the sneezing sound that it otherwise might communicate. I'm really honored to be here this morning in such a beautiful venue with such a large crowd. This is likely one of the largest crowds that I've spoken to about our work, and it's really exciting to see how the concept of value-based healthcare is catching on both in Australia as well as globally, with the OECD recently taking hold of the concept and intending to work with us towards a program to measure patient-reported indicators across OECD countries, as well as individual countries really paving the way. And a lot of that work is happening here in Victoria and in Australia more broadly. So it's very exciting to see that the theme of your event is value and that you are on this journey to transform healthcare. It's a topic that I'm quite passionate about. I've spent my entire career, for the most part, on, whether it be around new models of paying for performance and delivering new models of care to quality improvement and health system performance. And now, today, with the International Consortium for Health Outcomes Measurement, which I'm very grateful to be a part of and be able to move forward this idea of measuring things from a patient perspective, things that matter to patients, and being able to make those data available and transparent to both clinicians to make more informed decisions about the treatments that they should provide and which will optimize outcomes to patients, as well as making those data hopefully transparent to patients themselves to make better decisions about whether treatment is the best option, and if so, where to receive that treatment to maximize or optimize their outcomes, to make sure that they're getting back to doing the things that they love, whether it be gardening or sailing or spending time with children or grandchildren. That's our goal, is to make sure that treatment results in more than just survival, but people are getting back to full health, they're sustaining that full health so that they're leading happy and productive lives again. So hopefully by the end of my talk, you'll be convinced that value-based healthcare is the paradigm, is the model that we need to use when we think about how to change our system. But before I dive into the content, and thank you both Angela and Zoe for not making any jokes about the US politics. I did want to just take a second to disclose and be very transparent about any conflicts of interest that I have as an American. I actually don't have any conflicts of interest to declare, but I would like to declare that the following presentation contains no alternative facts. I was actually asked at a presentation last week this very question, so I just want to make very clear up front. It's also not fake news. This is actually happening. It's happening all around the world. I'm going to give you one example from a clinic in Germany that has led the way, but if there are any fact checkers or media in the audience, I welcome you to do your work with due diligence here today. And finally, in case it's not completely obvious yet, yes, I voted for Hillary and Obama twice. I'm very proud to have voted for a US president who has worked to make healthcare closer to a basic right in the United States, and that's something that I believe very deeply needs to happen. All kidding aside, though, it's come to my attention in the last 2 weeks here in Australia that you, I think, as well as the rest of the world, pay fairly close attention to what's happening in US healthcare policy and politics in general. So I did want to say a few words about that situation. And I use the word situation very arbitrarily because I had a graduate school professor who once told me that the difference between a problem and a situation is that problems have solutions. And I think what we have in the U.S. right now is a situation with the Democrats and the Republicans really at an impasse and struggling to agree on what the best way forward is. And so there's not only a division between parties, but there's really divisions within parties if you look at what's happening with the Republicans today. And I think it's a reflection of the fact that we have some really big challenges that we're facing. And it's not that people don't want the same things. Everybody wants good infrastructure, a strong middle class, secure borders, a high-performing healthcare system. It's just that we have very divergent views on how to achieve and solve those challenges. And specifically with regard to healthcare, this is the challenge that we face. Just to orient you to the charts, these are all indexed against the current state as of 1995 and show the difference in healthcare spending plotted against the growth in income and GDP. And what you'll see here is that everywhere we look in the world, healthcare spending is growing at a faster rate than both GDP and income. And as we all know, that's just simply not sustainable. So the US here has the unenviable distinction as leading the world, now with 18% and growing of our GDP going towards healthcare. But you'll see, as you see here, and I think Australia is no different, everyone is on this same trajectory. And in fact, while these charts only date back to 1995, our healthcare spending problem or challenge dates back all the way to 1970 or 65 with the passage of Medicare and Medicaid. And as the story goes, one of Lyndon B. Johnson's top advisors told him that simply to get Medicare and Medicaid passed, he would have to kick all of the economists out of the room. And that's exactly what he did. And now you see, the trajectory that we're on as a result. And I'm a huge supporter of those programs, so don't get me wrong. But we need solutions today that curb healthcare cost growth and get us back on track. And hopefully you'll agree with me that value-based healthcare is the way to go. I did some quick internet search last night and looked at OECD and WHO numbers and found that while Australia, I don't have on this chart, appears to be around 9.5% or so of GDP and growing at a rate of about 2.2% per year, faster than GDP and income. So while you're not quite where we are, you're definitely, again, on that same trajectory. And of course, spending in and of itself isn't necessarily a bad thing, so long as you see returns in terms of health achieved from those additional dollars that are being spent. But the fact of the matter is, and I could put up any number of charts and figures to back up this point, we're not seeing that ROI on the additional dollars that we're spending in healthcare today. And not only that, but health outcomes remain highly variable and uneven at best. This slide represents the work that a few of my colleagues did a few years ago, where they literally spent a month or more pouring through the literature looking for evidence of outcomes, of variation in outcomes at the national or international level. And what you'll see here is, A, there's not a lot of evidence available to show, to truly describe what we're achieving and what the variation is on the end results of care that we're providing. The other thing that you notice here is that where we do have this evidence, it tends to be on more traditional or basic measures. All 7 of these either look at mortality, surgical complications, or reoperations, things that are happen within the hospital or intraoperative time. And so what you're not seeing is, again, what is the quality of life of these patients 1 year or 2 years or 3 years after surgery? How much pain are they in? What is their functional status? And these are the things that I think are really meaningful to understand if we want to move to a higher performance healthcare system. And really, as a result, we've spent the last 50 years or so kind of layering incremental fixes on incremental fixes to try to bend the cost curve, if you will. In the United States anyways, and I think globally has unfortunately maybe followed suit, we've tried things like care navigators, we've tried things like gatekeepers and HMOs, we've tried capitation, we've tried per member per month incentives to deliver higher quality care. And while some of these things have had marginal results and improvements, none of them have really been the kind of silver bullet that we're looking for or that we need. Yet we continue to do it because it's easy. It's easier than trying to transform an entire system, to turn a ship the size of the Titanic, at least in the United States, where we have 320 million people and growing daily. So now, today, we're in a situation where we have Democrats on one side saying, well, the answer is to increase access to care, have better preventive care and primary care services, and as a result, costs will come down because we won't have as much need on the health services and on acute care facilities and hospitalizations. And so they're focused on access, but not really on cost, not really on quality. And the Republicans are saying, well, we're going to focus on cost, and we're just going to simply cap spending. And sure, that's probably effective in terms of controlling costs, but the goal here is not to provide access to uneven or variable or poor quality of service, and it's certainly not to reduce cost at the expense of quality. And so that's why we believe it's time for a fundamentally new strategy for healthcare, a transformation. And we call this strategy value-based healthcare. Now, I think the term value is up there with patient journey and activation and engagement as maybe some of the most widely used and poorly understood or aligned on in terms of definitions. So I just wanted to take a moment to be very clear about what we mean when we talk about value and value-based healthcare. And this is a theoretical equation, but it's the framework and equation that we use to describe value-based healthcare. And as you see here, it's health outcomes that matter to patients. So things that I mentioned earlier around functional status, pain, and those are measured through patient-reported outcomes. So we ascertain these outcomes directly from patients relative to the cost of delivering those outcomes. So when we talk about cost, we don't talk about reimbursement or system-level costs, things that you can assess through claims or through administrative data. We're looking at the inputs that go into delivering the care. What is the actual cost of the device we use, of the theater time, of the physicians and nurse teams that are providing that care? And we believe that this has to be the overarching goal. And in fact, we believe that it's the only goal that can truly unify all of the different stakeholders within the healthcare system. And while we believe that all stakeholders have a role to play in this transformation, whether you're a funder, a life science or med tech company, or a provider, we really believe that it's the health services that have to take the leading role in this transformation. And that's because value-based healthcare, at its most fundamental level, is a restructuring of how care is delivered. So let me just elaborate on that point for a brief moment. Now, currently, we're stuck in a system, a legacy system, I would say, that is really organized around what clinicians and physicians do rather than what patients need. And this is what it looks like. We have silos of specialties and departments that don't communicate very well with one another, more or less cooperate with one another to figure out what the best treatment option is for an individual patient. We have measures of process and compliance that don't really look at the outcomes of the procedures, but make a theoretical linkage between what we believe are best practices and the outcomes that they intend to achieve. And then we have, of course, a fee-for-service payment system that I think all of us realize doesn't correctly align the incentives with quality. And we have loose confederations of hospitals that are doing duplicative services despite the fact that they're part of the same system, rather than organizing, reorganizing, and concentrating value within centers of excellence. And finally, we have, at least in the United States, we have an information technology architecture that is really built and meant for optimizing the documentation of care rather than optimizing the results of care. So this is where we think we need to move. And this is what we at Harvard Business School consider the value agenda. And it comprises 6 interdependent and mutually reinforcing components. And those are the ones that you see here on the right side of the slide. And really, if you look at it, what you see here is answers to fundamental questions that health service providers must answer in order to deliver high-quality care. Questions like, how will we organize our service lines to optimize outcomes for an individual or a given patient? How will we fundamentally, as an organization, define success? How should we be reimbursed for our care? And importantly, as I mentioned a moment ago, how do we move from a care documentation platform to a care optimization platform? Now, this is all great in theory, and I would invite all of you to Boston, to Harvard Business School, where you can spend a day on every single one of these components, pouring through case studies and examples. But I wanted to take a moment to bring it down a level and talk about what it really means for patients and for care providers. So I'd like you to imagine just for a moment that you've recently been, or you've had a loved one who's recently been diagnosed with prostate cancer, a disease that is rarely fatal if detected early, but whose treatment can have side effects that are devastating to one's quality of life. What would be the first thing that you would do? Whose advice would you seek on what treatment to undergo? Would it be surgery? Would it be radiotherapy? Would it be focal therapy if you have advanced disease? Or would it be potentially watchful waiting or active surveillance? And what hospital would you choose to go to receive that treatment? Well, if you're in the United States, chances are is that you'd go to Google, or you go to the internet, to one of these sites, US News or Consumer Reports, and figure out what's the best hospital in the United States that I can get treatment at. But the problem is that these hospital ranking systems are typically based on reputation, number of peer-reviewed publications, structural measures like staffing ratios and patient volumes, rather than the true outcomes of care, the things that patients really need to make informed decisions about where to go. So shifting now maybe towards clinicians, what's in it for physicians, for many of you in the room? And I would argue that it really boils down to 2 things: motivation and satisfaction. I think we've all seen troubling statistics that show the poor job satisfaction among physicians today, and I think it's largely due to the fact that we have a system that doesn't intrinsically motivate people. Some fascinating research has been done on this topic, and basically what it says is that for jobs in widget factories, for example, carrots and sticks, incentives and penalties actually work pretty well for achieving the desired behavior of workers. But for jobs that require higher level cognition, these things almost always fail, and not only fail, but oftentimes backfire. Yet, we do know what a better mechanism is. And we know what leads people to do better performance and better satisfaction. And it's these 3 things. The first is autonomy, the ability to be self-directed in your work. The second is mastery, or the ability to continuously improve at something that is really important to you. And the third is purpose, the sense that what we do serves something meaningful beyond ourselves. And this, I think, is what's really beautiful about value-based healthcare. Because value-based healthcare, I think, provides all of these things to clinicians. It says, we don't care if you use guidelines or checklists, so long as you achieve good outcomes. We don't want to constrain the way you deliver care. We want to give you the opportunity to innovate and deliver care as you see fit. And we're just going to focus on the results of that care. And we're going to give you the data and the feedback you need to innovate and improve. granular data, real-time data, to make sure that you are able to achieve the results that you intend to. And finally, we're going to help you achieve the best possible results for your patients so that you can ultimately achieve the purpose that brought you into the profession in the first place. Now, when I think about clinicians and patients and value-based healthcare, the example that always comes to mind for me that really typifies this model or this framework is the Martini Clinic. Now, if you are walking through the University of Hamburg campus, you might actually miss the Martini Clinic. It's not much from the outside, but there's certainly something special happening inside this building. And the clinician that has really spearheaded the initiative there is this gentleman, Professor Hartwig Buland. And Professor Buland had trained at Stanford as a young physician and had seen how care was organized around patients and how data was used to inform quality. And when he got back to Germany and took a post in the urological department, he really wanted to implement a lot of those ideas. And at the time when he founded the Martini Clinic, he had, in many people's eyes, reached already the pinnacle of what a surgeon and a urologist might hope to achieve in their career. He was appointed chair of the urological department at University of Hamburg. He had access to all of the private pay patients. He had a shiny sports car, I'm sure, probably a Porsche, because who wants to buy domestic in Germany? And really kind of had it made, but it wasn't enough for him. He said, I want to use outcomes to challenge the status quo, to adjust old methods and uncover better ones. And that's exactly what he did. And he did this kind of in using what I would characterize as 3 steps. The first thing he did was he organized a team around the patients. And I apologize if the font is a little hard to read. I'll talk you through the points myself. So he went out and he found all of his former colleagues, trainees that he had worked with, the best urologists in the region, and he said, let's start a dedicated center where all we do is treat prostate cancer. And he put together a multidisciplinary team to support those urologists. That included not only the surgeons, of course, but radiotherapists, oncologists, nurses who are specifically and specially trained in prostate cancer care, physiotherapists and psychologists, social workers who spent their entire day doing nothing but treating patients with prostate cancer. And the importance in this is that there is mounting evidence and ample evidence of an association between volume and quality. We see cases all of the time, and in fact, a number of countries are now starting to put limits and say, if you're a hospital and you don't do X number of procedures a year, then we're not going to reimburse you for the procedure anymore. The second thing they did is they assigned a faculty member to each patient to guide them through the entire patient journey, to make sure that they had a single point of contact that they knew, that they trusted, that was available to them at all time. But this individual didn't just assign a treatment modality. They guided the patient through the journey and brought their case in front of a multidisciplinary tumor board to discuss with their other colleagues and determine what the best treatment option would be. And then they integrated the outpatient physicians through regular meetings, letters, and education programs. And in Germany, the system is such that there is a strong bifurcation between outpatient and inpatient care. And so they couldn't necessarily help the patient all the way through the full cycle of care, but they did their best through this kind of structured outreach and patient education. The second thing they did was they created a culture of excellence within the organization. And the first thing that they did in order to achieve this was they flattened the organizational structure. So despite the fact that Professor Buland had years of experience on his other colleagues, he considered them all equals. They had equal pay, they shared bonuses, and if you talk to Professor Buland, he would say, it's thrilling to be able to go to work every morning with 9 or 8 other colleagues who are all international experts in prostate cancer care. That's what makes going to work there intellectually stimulating, intellectually fun every day. And each was allowed to pursue their own subspecialty as well. Furthermore, they were encouraged to and given time to conduct their own research and to innovate. And we'll see an example in just a moment of how that innovation led to improved patient care. And then they created mechanisms to discuss individual patients, and the key here is in an open and transparent environment. They actually looked every 6 months, they looked at the data, they looked at the outcomes that each individual operator was achieving, and used that to determine who was doing well, why they were doing better than others, and to retrain even some of the physicians and surgeons that were scoring lower. And ultimately, what they did was they made patient-centered outcomes the true measure of success. And this is what they did when they focused on outcomes. For every patient that came to Martini Clinic, they measured at baseline, at 6 months, 1 year, and 2 years, not only mortality, but the patient-reported outcomes that are meaningful to the individuals. Things like erectile function, quality of life, incontinence, urinary function, complications, and metastasis. And then that data was systematically analyzed and, as I mentioned, discussed every 6 months. And in fact, if you read the Harvard Business School case study on this, there's a fascinating example of how Hartwig Buland himself had higher than average surgical margin rates and retrained with a junior surgeon in order to bring those down, to learn the newest and the latest techniques. I think it's a real good example of how teamwork and innovation can lead to better patient care. So let me show you the impact of this culture and this system and this focus on outcomes that they created. This is a chart that shows, on the left, you see pads per 24 hours, so it's a measure of urinary continence. And on the x-axis down below, you see monthly percentages. And one of the surgeons at Martini Clinic decided he had read something in a relatively obscure Korean medical journal about improving urinary continence through sparing more of the anatomy of the prostate during prostatectomy. And where the line here goes from dashed to solid, you see this is where he implemented a new technique that he had developed. And almost instantaneously, you see the improvement in patient-reported outcomes. So he ran off and he told his colleagues, hey, I think I'm onto something here. I want to share the data with you, and I want to share the technique with you. So he invited two of his colleagues to scrub in on the next surgery and learn this technique. And this is what we found. This was the second surgeon. Almost identical results, but just shifted 1 month later. So this technology and this innovation is diffusing extremely rapidly. And then the third surgeon, again, maybe not quite the same magnitude of improvement, but fairly significant nonetheless. Now, when this diffused through the entire organization and over the course of 10 years, this is the result. You see that on 5-year survival, on traditional measures, there's not a whole lot of difference between Martini Clinic and the average German hospital. But when you look at these patient-reported outcomes, things like severe erectile dysfunction and urinary incontinence, you see massive differences. And again, this is the result of creating that culture of excellence, on focusing on outcomes and focusing on those outcomes that really, truly matter to patients. So you may say that's nice, but what does it mean for Martini Clinic's organizational success? Oh, sorry, before I get that, I just wanted to show you one other chart that I think is maybe not most intuitive, but is extremely fascinating. And this shows the Martini Clinic's institutional learning curve over time. So on the bottom here, you see the number of cases. So this line would represent the urinary incontinence rate of Hartwig Buland over time, from when he first started collecting data on himself to his 4,500th operation. And you could see his own improvement. But while his own improvement is impressive, what's even more impressive is how that experience translated to other colleagues within the Martini Clinic. So this is the next colleague that began measurement, and the next, and the next. And you see each person that came in and began operating and began measuring their results started at a higher rate and was able to improve faster for the most part. So as I mentioned, you might be wondering what this means for Martini Clinic's organizational success. And this shows their case volume over time. From 2005, when they became independent from the University of Hamburg, to 2011, they grew at a rate of 18% per year in their case volume. And the only reason they leveled off was because they ran out of capacity. They literally couldn't treat any more patients. And this is just one other way of putting that into perspective for you. They're now the largest prostate cancer center in the world, larger than the US's two highest volume centers, Mayo Clinic and Hopkins, and doing 4-5 times more procedures per year than hospitals in Germany in the 99th percentile by volume. So hopefully at this point, you're fairly convinced that outcomes measurement is the way that you need to go as an organization. So the question becomes, where do we begin? What do we measure? And how do we know that we're aligning with an international standard so that we'll have the ability to measure and compare and learn? And it's stories like the Martini Clinic and that reason specifically that led to the establishment of my organization, of ICHOM, as an independent nonprofit, really with the goal of defining core outcome sets that measure what matter to patients and to drive adoption of those and the reporting of those outcomes globally. And just a few words about the methodology we use to create these outcome sets. And I should note that Hartwig Buland was a working group lead for our standard set in prostate cancer. But I just wanted to make you all aware, hopefully maybe you already are aware, that we're currently in the middle of a process to create one of these outcome sets now for oral health. And as I mentioned at the beginning, the department, the DHSV and Deb Cole have been instrumental in both supporting that work and participating on the working group as one of these experts. So the process that we use is really to form working groups of specialties, of experts representing all of the different specialties that treat a patient with a given medical condition, bringing registry experience together, bringing patient voice to the group in the form of patient representatives and focus groups, and take them through a structured process over the course of 8 to 12 months, depending on the condition, to come up with a standard minimum data set that answers the question, if I'm a patient with a given medical condition, what does success look like for me? And so we do this according to a few framing principles. The first is that, again, we work at the condition level, and that's because we want to be able to understand not only what the best treatment option is for someone with a given medical condition, not necessarily which hospital or provider to go to for a given treatment. The second principle is that these are minimum sets of outcomes. We don't include process measures or experience measures. We want to set the dial and set the goal and allow, again, service providers to investigate linkages between their processes and the outcomes. And this allows us to have a static set with some fluid measurement underneath. So we encourage service providers and hospitals to add those experience measures, add those process measures to do the type of innovation work that the Martini Clinic did. 3 is that patients are always directly involved in the development of our standard sets. As I mentioned a moment ago, we have patient representatives that actually serve on the working group, but we also do quantitative surveys and focus groups to ensure that what our patient representatives are telling us is truly representative of a range of different cultures and other factors that we want to make sure that we're capturing. The 4th is that patient-reported outcomes are included in every standard set. And of course, at this point in the presentation, hopefully you understand the importance now of including the patient's perspective in a way that isn't interpreted by clinicians, but is captured directly from their assessment of their own health. And in fact, some of our standard sets are almost entirely patient-reported. 5th is that we include a minimum set of initial conditions and risk factors, which is necessary to draw apples-to-apples comparisons when we're looking at performance of one hospital or one system to another. And finally, time points. We want to make sure that not only are we measuring the same thing the same way, but we're measuring it at the same time again, to ensure comparability and compatibility of those results. So this is just one example from localized prostate cancer. Unfortunately, I don't have the working group for oral health available for you today, but you can imagine that it's very similar in terms of the geographic distribution and the distribution of specialties that are participating on the group. We are trying to involve more clinicians from low and middle income countries. This was one of our first sets. So we do have a lot of representation from North America, from Europe. And just to note, almost all, I think all but one of our standard sets that we've developed to date have had clinician and or representation, patient representation from Australia. And then this is the final result. So once the working group has completed its job, has aligned on this minimum core outcome set, we create what we call an outcome wheel. And this is just a very high-level overview of the outcome domains that we hear from patients are important to measure. And then we match those with validated questionnaires and instruments to measure those things in a reliable and valid way. And then underlying this high-level view of the standard set is a peer-reviewed publication that discusses the different trade-offs that were made on the working group and the different discussion points that led to the decisions, as well as a reference guide that includes a data dictionary and coding instructions for your IT departments, so that, again, to make measurement and comparison and learning that much easier. So we've done this 21 times to date. We're doing 8 more at the moment, including oral health, as you can see here in bold, and we do it across a range of different medical conditions, from pediatrics to musculoskeletal to orthopedics and oncology. There's really not very many areas that we haven't touched yet. We've even started to get into more population-based measurement with older persons and overall adult health now. And our goal is to, by the end of this year, have 50% of the disease burden covered, and we're not going to stop until we have probably 50 standard sets covering the vast majority of the disease burden available. So with that, I just wanted to wrap up, because hopefully this has again, been both informative but also inspiring to you to get started. And I just wanted to share 5 lessons very quickly that we have learned in working with providers all around the world in terms of how to take that initial step and where to begin. And it really starts with leadership. And I think that you already have a head start here with the buy-in and dedication to this journey with the leadership of DHSV. But it's not alone to have the administration bought in, and we need leaders from the clinical side as well. So what I would encourage you is that if this is something you're interested in, make yourself known, put your hand up, say, I want to be the Professor Buland of oral health. I want my clinic to be the next Martini Clinic of oral health. Number 2 is that outcomes measurement is a team effort. We've already seen this with Martini Clinic, but it's true across all conditions. When you're working across specialties, when you're implementing new processes and new measurement, it's often a long journey, and it takes commitment and teamwork to make sure it's important. And all of those different individuals that are involved in the measurement process need to be bought in. They need to have a voice. They need to be able to have an opportunity to express their concern, if there are any, or to feel like they have a role to play in the process. Number 3 is that there's no right way or one-size-fits-all solution to doing this. There's no 2 implementations I've been part of that have been the exact same. The key is just to start somewhere, to figure out what works for you, for your budget, for your condition, for your team, and to go from there. And along that same vein, it's critical that you just get started. A lot of people become paralyzed by thinking that they need to design the perfect system or have the perfect solution right out of the box. And in our experience, the best thing you can do is just to start small, start with an understanding that the system isn't going to be perfect, and just work over time to improve it. And then finally, make the data accessible and make it actionable. If you look at the literature around patient-reported outcomes, the best evidence for impact currently is on the individual patient-provider interaction, improving communication, improving patient activation, improving shared decision-making. And if you're collecting this data and it's just going into a database that's pulled once a year for research or other purposes, that's not actionable, it's not going to have as much of an impact as you might otherwise achieve. So I'm going to stop there. I hope this has been helpful, and feel free to come up and ask questions afterwards. I'll be here all day. I'm not sure if we have time for questions. I have a feeling I went a little over on time.
We'll end it there, but you're hanging around, aren't you?
I am. Thank you very much, everyone.
Now, thank you, Jacob, for presenting that global perspective and also a very compelling case as to why we should focus on patient-reported outcomes. That was terrific. We have a gift for you, of course.
Thank you.
This on the card. Thank you for joining us.
Thank you very much.
Okay. And I liked your disclaimers at the start as well. That was terrific. Our next speaker is Dr. Diane Watson, the CEO of the Victorian Agency for Health Information. Dr. Watson was the inaugural Chief Executive Officer of the National Health Performance Authority that was established by all Australian governments to monitor and report on the performance of 1,000 plus public and private hospitals and 300 plus health regions. Dr. Watson was also the inaugural Chief Executive Officer of the New South Wales Bureau of Health Information. Please welcome Dr. Diane Watson.
Thank you very, very much for the introduction and for the invitation to be with you here today. And wasn't that presentation that we just saw fantastic? I think that the pairing of these two presentations together is going to be really, really useful to you, because my intention today is to bring it right home to Australia, to tell you about your own healthcare system and why this topic of health outcomes and value-based healthcare matters to Australians. And I have a few examples to bring it right home. To those of you interested in Victoria's healthcare system, I have stayed away, however, from dental health. It's not my area of expertise, but have roamed across the healthcare system in the slides on various topics just to show you that wherever we look, we find the same kind of thing, the same kind of experiences around the need to focus our attention better on outcomes and processes of care that lead to better outcomes. So I'll challenge you through the presentation then to think of your own practice, your own local health system in the areas in which you specialize to see if you know of your own examples where similar things are occurring. So just one slide about the Victorian Agency for Health Information. I bet many of you may not know of the organization. The reason for that is it's only about 3 months old. I will talk later on at the end of the presentation about the agency, but I just wanted to let you know the backdrop of the agency and setting the stage for why I was invited to present to you today. Is throughout 2016, as you may have been following in the newspapers, and if you follow announcements from the media and from the department, there was a review of quality and safety across all of hospitals in Victoria in a response to an acute cluster of potentially avoidable deaths that occurred prior to 2016, and the magnitude of impact that has on patients, to know that has occurred in Victoria, the impact that has on families, the impact that has on a health service, and therefore our health system as a whole. That review concluded towards the end of 2016 and will result in significant reforms in Victoria that will roll out over the next year to 2 years, with the establishment of Safer Care Victoria to provide statewide supports where you need supports the most in terms of improving quality and safety, and also the establishment of an information organization to help you focus your care on health outcomes, learn about models of care that can improve and provide better, safer care for Victorians. So let's move specifically then into the topic of health outcomes. Why so many people care about this topic today? Who is it? Right from the Prime Minister and Premiers through health ministers, through departments, through clinicians, to patients, carers, and families about why health outcomes are so material to the dialogue today about improving our healthcare system. And then, as I mentioned a few minutes ago, well, let's talk about Victoria's response to better manage risk, to safety and quality in care, and to promote better health locally and right across the state. If you think about health outcomes and the topic of the presentation that we just had, what's coming more to light to so many different people is the lack of a clear relationship between three real elements in our healthcare system. One is inputs, the investments that we make, as you see from Jacob's slides, the size of those investments, the deployment of our healthcare workers, the deployment and use of technology, the relationship with that in terms of inputs into our system, the processes of care and how we vary in our practice and models of care to deliver different types of services for the similar types of patients with similar conditions, as you saw in Germany, and that we can alter those models of care that have very material implications for the outcomes of patients. And think of outcomes much, much more broadly across very different clinical conditions. Outcomes such as some examples. Services that are intended to promote health, to prevent illness. Some of our services really focus on reducing the duration of chronic condition, delaying or reducing the impact of chronic conditions, reducing the risk of complications, either of a chronic condition or complications from surgical procedures that we undertake in our health service. You could do services that reduce the future need for health services into the future. Focusing on well-being, we can focusing on improving life expectancy or the quality of life within the life that we have available to us in terms of palliative care, as an example. So lots of different constructs in which we can focus our attention and our information systems better to provide you with better information, to understand the impact of varying models of care on the benefits that are received from patients and the public from the interventions that we do. So why should we care about health outcomes? Let's just think about Victoria and that report that I mentioned that was completed in late 2016 that resulted in the establishment of the Information Agency and Safer Care Victoria. Australian research suggesting that 1 in every 10 patients suffers a complication of care during their hospital stay, and half of these complications are indeed avoidable. Indeed, every year more than 300,000 patients suffer complications in Victorians' hospitals. Those are leading statements in the executive summary of the review of quality and safety in Victorian public and private hospitals that was completed last year. So let's look across the nation, across different areas of healthcare, and look at the relationship of why this is ubiquitous, of the lack of a relationship between our investments in resources into a healthcare system, the varying models of care that we deliver to similar patients with similar conditions, and the varying outcomes that they have. This slide really is at the macro and is actually an extension of the slide that Jacob was showing you. And it shows the relationship or the lack of relationship between our investments in our healthcare system and the outcomes for the population across a number of different countries. So just one slide, just one glance at the relationship or lack of relationship between spending, which is across the bottom, and our health, which is up across the top. And this is a slide created from the Bureau of Health Information in New South Wales. So it's put New South Wales right in the middle with the blue lines across it, but Australia, you'll notice, is right next to it. So the same concepts are true in New South Wales, but also in Australia. So this is taken from the Bureau of Health Information. What this slide shows is, very important to Australians, Prime Minister, and premiers, health ministers. If you look at our spending right in the middle, Australia and New South Wales there, the middle of those crosshatch of the two blue lines, if you spend more going to the right and you followed profiles in other countries, you actually see poorer health. They're all up in the top right-hand quadrant there. And Jacob, I put a little dot there for you for United States, because they spend 3 times as much per capita, 3 times as much as Australians spend for every single person in this country. They spend 3 times as much, right? We're at 5, they're all the way over at 15. Look at health outcomes, much, much worse. Top right-hand quadrant there, United States. So the lesson here for Australians and the lesson here for the Prime Minister and Premiers is that you can spend more in some other countries and actually have poorer outcomes. Lack of a relationship then between inputs into your healthcare system and the outcomes for a population. Just at a glance, just one slide. So how does this kind of happen? So the next couple of slides give you just little examples about how this can happen, about a relationship between spend and models of care that you buy with the spend and the outcomes for patients. So this is just one slide to show you a relationship or lack of a relationship between spend and health. So one example is we can be spending too much money on care that's of very low value. 2 examples. Across Australia, there's a certain procedure for knees that is performed despite evidence that the procedure has very, very low value for certain kinds of patients. In fact, 33,000 of those interventions happen every year in Australia. And in fact, where you live depends on whether you get it or not. There are some communities in the country that you're 7 times more likely to get this procedure than in other similar communities. 7 times. CT scans are conducted every year for lower back pain despite clear guidelines restricting their use. Australians in some communities are 12 times more likely to get that procedure for that condition than they are in other similar communities. So just 2 examples of very large investments, high volume, 33,000, 314,000 procedures provided to Australians for procedures linked to conditions where evidence suggests there's actually no value or benefit of undertaking them. So that's just examples on low value care for certain kinds of patients. So let's look at high value care and how much we provide high value care, because there's also evidence that we do a bit too much of this to some people. So a couple slides on this one. Antibiotics, clearly high value care. Did you know that Australians per capita are twice as likely and consume twice as many antibiotics as Canadians? Now, why is that? You might say it has to do something with the weather, but I'll prove your point wrong in just a minute. It has nothing to do with it being much more hotter and tropical, and Canadians live in snow and in igloos. Not the case. In Australia, for example, this is very, very material. In Australia, 30 million scripts for antibiotics. Even the most common antibiotics is amoxicillin. 6 million scripts per year. Twice as likely to get those prescriptions as Canadian. Now, antibiotics, where is this prescribing happening? You're 10 times more likely to get an antibiotic in Australia, or 11 times more likely in some communities than in other communities to get those scripts. In fact, one antibiotic called quinoline's, very restricted process to gain access to that. You're 8 times more likely to get that prescription in some communities than you are in others. So if you think for a minute, which is what the committee that oversaw this work of clinicians leading in this area of antibiotic stewardship, because it's a high concern of overuse of antibiotics, both to the Australian government and the WHO, and how much we're dispensing these high value treatments. is they said, oh, it must be all in like tropical locations, et cetera, where we're much more likely to be exposed to things. That's not the case. Guess where the community is that has the highest rate of antibiotic prescriptions by far than anywhere else in the country? For those of you that are flying home today, you're going to go out to a community by the airport in Melbourne that has the highest prescriptions of antibiotics anywhere in the country. Just down by your airport. Okay? Why is that? Who knows? Who knows? Who knows? Must be models of care, clinical practice, influenced by prescribers, and they prescribe how other prescribers do in their community. Alternatively, there's a dispensing machine on every corner, down out by your community, down out by your airport. Okay? This is PBS-funded prescriptions, antibiotics. Let's move on. Other models of care. Here's some examples of models of care, care provided in hospitals for very, very standard procedures, common procedures. We looked across 16 of them. Guess what was found? Common conditions. The length of time that you spend receiving care for a common condition across just looking at major metropolitan hospitals, not thinking rural or regional, because your length of stay might vary for certain conditions in certain regions in those areas. Just major metropolitan hospitals, 16 of the most common, prevalent, simple conditions, 2- to 4-fold variation in length of stay in Australia. Here's an example, knee replacement. About 5,600 of these procedures each year. Length of stay, major metropolitan hospitals, 3-fold variation. Anywhere from 3-day length of stay up to 10-day length of stay. And I'll tell you, on average, every single one of those days, extra days, for every single one of those patients costs approximately a few $100s over $1,000, depending on what hospital you're in. So $1,200 to $1,500 on average per day, per patient, for extra days. And there are major metropolitan hospitals, there's one in Western Australia, major metropolitan hospitals, 10-day length of stay. All right, so what's the difference, what's the impact of all this variation in spend and variation in prescribing patterns, variation in models of care? Just giving you some examples, could give you many, many, many more, on outcomes. So just 2 slides as examples for outcomes. Diabetes admission for lower extremity amputation rates in Australia, all depends on where you live, 11 times more likely to have a lower extremity amputation as a complication from diabetes, depending on where you live in Australia. If you look at that map on the right, you would think that, and it is true, that the higher rates are in regional and rural areas where we have high populations of Aboriginal and Torres Strait Islander peoples. However, look at the map in Melbourne. Even in Victoria, you're 3 times more likely to have lower extremity amputations as a complications of diabetes, depending on where in Victoria that you live. Okay? Clearly a complication we want to avoid. Clearly an accumulation of a deterioration in health to such extent that you need to have a lower extremity amputation, but that's 3 times more likely to occur depending on where you live in Victoria, 11 times more likely to occur if you live in one community versus another right across Australia. Another example about complications more broadly across a collection of chronic conditions, hospitalizations that could have been avoided with better treatment and management of those chronic conditions in primary care communities. 10-fold variation in the likelihood that you'll be admitted to hospital as a complication of a chronic condition in Australia, all depending on where you live. Okay? So clearly, no matter where you look, prescribing, no matter where we've looked in prescribing, be it antibiotics, anti-anxiolytics, antidepressants, etc., we see the same patterns as I described to you in antibiotics. 16 different high prevalent, high volume, common clinical conditions where we know what the best models of care are in hospitals, 2- to 4-fold variation in length of stay in hospital before people are ready to go. And that's just in major metropolitan communities in the country. Variation in outcomes. I've given you an example just for diabetes, and I've given you an example of outcomes that we can measure for people with chronic condition. This lack of a relationship between how much we put into a healthcare system in terms of funds and providers and technology, and the models of care that happen in our local communities as we write prescriptions or as we provide care in a hospital from admission right through to discharge, that model of care results in very, very different length of stays, which has huge resource implications in terms of occupying beds and keeping people in hospital when they would rather be at home. And variation in outcomes has come to the attention of lots and lots of people in the country. Clearly and most importantly, the most material impact of all of this variation, particularly in outcomes, is to patients, carers, and citizens. They care about variation in outcomes. They also care a lot about the inputs and expenditures, not only from taxes, but our gap payments. And look what's happening to private health insurance premiums over the last 5 years. Relative, the growth, year on year, 5% per year in private health insurance. And what's happened to wages in the last year in Australia? Stagnation. Private health insurance, 5%, 5%, 5%, 6% last year, right? They're concerned not only with the inputs, they're concerned with the outputs and beginning to wonder, why does it matter where I go and where I live that I get a different type of patterns of prescribing, experiences in hospital, model of care, and different outcome. All of what I've described to you is not new to the Prime Minister or the Premiers. It's not new to health ministers. It's not new to ministries and departments of health. They are on to this, which is why the establishment of Safer Care Victoria, and why the establishment of the agency in Victoria to help you collect and use and better use the information that we have in Victoria about care and about patients to help your boards, your chief executives, and your clinicians in your organization to work towards an agenda of better, safer care, focusing on health outcomes. Colleges also, and many lead clinicians naturally are obviously onto it. Even all the work in the antibiotic stewardship that I described to you in a couple of slides. There's large groups of clinicians who've been working in the year and a half or so since we finished that report, trying to improve the situation in Australia. Your own strategic plan is such a nice document to read, as I read it a week and a half or so ago, preparing for this presentation. It really, really focuses on outcomes for patients, where we want to improve health outcomes. Have a read of the document if you haven't already. Congratulations to those who've been involved in its creation. It very much focuses your attention on outcomes for the people who you provide care to, and the models of care, improvements that you will make to better deliver on outcomes for the people that you see, to ensure that the right care is provided to the right person at the right time and the right place, and to do that through partnerships, a better and stronger evidence base that we hope to help you with, technology, and changing culture and capacity so that you can all work towards that trajectory together with your patients and your partners. Let's just come back to the agency just quick for the next couple of slides. So that was a macro kind of view of why all this matters to Australians and to so many people working to strengthen the healthcare system in Australia, and Victoria in particular. So let's zoom in on Victoria and that Targeting Zero report that's available to those of you who want to read. It's on the internet, released in October this year, that set the foundation for the government response, which is in a document that looks just like that called, that's the front cover, Better, Safer Care. The government's response to that review, which establishes really 4 mechanisms in which all of the recommendations in that report will be addressed. Safer Care Victoria, established to help you monitor and improve quality of care right across the health system. The new Health Information Agency, at the time we weren't named in terms of setting our legal foundation at the time, so it's just called the new Health Information Agency, now called Victorian Agency for Health Information. Victorian Clinical Council, which will have its first meeting today with a couple hundred clinicians. They had a pre-meeting in December, and the first meeting of that clinical council is being held today, which is why I'll have to leave you after this meeting to go and join them. They'll be providing clinical leadership advice to government, to each other, and to the health system to provide that clinical expertise to better drive safer care in Victoria. And we also have a ministerial advisory committee will help strengthen the composition, training, and supports and information that we'll be providing to boards to better oversight, serve their oversight roles in delivering better, safer care across the state. I just wanted to put this up. I'm not going to read through it, but there's a statement now for our brand new organization on the website. You can have a look about the kinds of things that you can expect to see happening this year from the agency. One of the things I've been asked a lot by clinicians, which is why I put this slide together, is how are you going to put all that information together for us, Diane, across all these different clinical areas and all these different health services, particularly the diverse health services versus the specialty ones, such as eye and ear, which I went and spent the morning with their board yesterday, and for dental. So I just wanted to leave you with a slide conceptually as a foundation for the organization where you'll see us move over the next year to 2 years. If you can imagine a day where we will put together for researchers across clinical areas, pooling information across our clinical areas and across our different information systems to have a pool of data that can be used by researchers or authorized users of outcomes and experiences from patients and from staff. So not raw data, but the result of experiences and outcomes by some clinical streams and by local health hospital campuses and health services in the state. A step up from that, much more liberalized information through interactive clinical portals. There is, I said to the executive at the health department when I first arrived to establish the agency, that I've never seen a jurisdiction that has more clinical portals and avenues of data flowing out of the department to the health services, but you don't have it together, because if you want patient experiences data, you go over there. You want length of stay, you go over there. If you want complications, you can't find it. You want mortality, you go over there. And health services, everyone just has to piece all that together to get a full picture of their health service. So that would happen in a more consolidated way with a clinical portal that's interactive for authorized clinicians to have a look down to see patterns of care as they compare across health services and see what patients they have in their own facility that are implicated. There is a need for what Ewan Wallace, the Chief Executive of Safer Care, and myself are naming a clinical PRISM report that will start in just the next couple of months, just a PDF document that gives a high-level view of comparative performance in peak areas such as, topic areas such as avoidable deaths, given what's happened in 2014, 2015 as the stimulus for the review, patient experiences, readmissions, complications that would go in a PDF document coming in the next couple of months. Some of those quality and safety measures will find their way into a document called the Statement of Priorities, and that is a contractual relationship that the department has with all the boards and chief executives that supports the flow of cash between the state and health services and has an array of performance indicators tied as conditions, obviously, to that accountability relationship between the government and health service boards. We just released last week the first board quality and safety report to 21 of the largest health service entities in the state. The rural and remote board report will come out just in the next couple of weeks. This is a document that's only about 30 pages, but it does have 4 board members information about quality and safety of their health service relative to other comparable health services in the state, and some peak measures of quality and safety, starting in the first instance with patient experiences. So there we are. Thank you for the invitation today. I look forward to a long and kind of prosperous and productive and relationship between you as the years go on from the first 3 months of the establishment of the Information Agency on the backdrop of the review of safety and quality that happened in 2016 in Victoria, and on the backdrop of the evidence, as I was describing to you, that we need to do much more work together, and our role is to provide you with that information to inform and energize and stimulate your efforts to improve care so that it's better and safer for all Victorians. Thank you.